Kind attention, everybody, on the screen. So first practical tip is go to a slice where everything is clear to you. So recollect, NMD was 2.5 on the left, 1.5 on the right, width was 4 centimeters, disease at cervix, and minimal parametrium on the left, right? And you had normal cervix, even at diagnosis on MRI. So in my mind, I am trying to identify where will be my height superiorly, where will be my inferior border, and parametrium. Okay, vagina was not involved, so I stop at cervix. Medially, right side, no disease, so only cervix border. Left side NMD was 2.5, medial parametrium. So I will go to a slice where this is seen very nicely. Okay, so let's say I go to a slice 50. Okay, so here, so here I would go, okay, select a structure. So you see, because of the bladder contrast here, anteriorly I can see the plane here. Can you appreciate that on your slices, on your screens? So what I would do is, on the medial side, I would not go into the parametrium on the right side. Maybe I use brush. Let's do it. Okay, so I do it here. On the right side, I go into this parametrial tissue here because on the left, there was medial parametrial involvement, and I would close here. So then there is some uncertainty here posteriorly. Can you make out? So what you should do is, yeah. So what we should do is go one slice above, one slice below, and see what it is. Can you see that? So it is part of sigmoid there. So always go one or two slices above, one or two slices below in the area where uncertainties is, and check how efficiently you can contour there. Okay? Okay, so now let's say, for example, in this region, it's very clear to me, cervix is here, anteriorly, going here, and then some extent here. Now your NMDs come into play here. Measure tool. This one? Yeah. It is 2.1 and my NMD was 2.5. Even if you're 2.5 or 2.8, doesn't matter. Few millimeters here and there, it doesn't matter because you're guessing. Okay, it is a guesstimate. Okay, so that is how you would shrink and make sure that your contour is efficient, because time and again when we used CT for contouring, in the parametrial tissue we always overestimated because we don't know what is happening on CT in parametrial tissue. Now we have reduced that by two things. One is clinical examination and I am measuring an MD. Second is, if you are doing a truss, then you have that measurement. By these two measures, you can very easily contour. So then you want to go down, go down. Before that, if you want to understand the anatomy, for people who have not understood, so this is the uterine artery on the right side, and if I go one or two slices above, that's the uterine artery on the left. Okay, so this uterine artery is the superior boundary of parametrial tissue in height. Okay, so your parametrial tissue is not there above it. Okay, so it means when you examine NMD, if it is 2.5, that NMD width will stop into the parametrium at this level. So it will not go into the parametrial tissue there. Is that clear? Yeah. And second thing is, whenever you are contouring, always have all these three slice orientation and get, even in the system you will have this, in your planning system you will have this option. Always go to a slice orientation so that you know where you are contouring. And I was telling quite a few of you that if you scroll through the sagittal section here, in this slice, can you appreciate that this is the narrowest part of uterus cervix, right? And second thing is, if you appreciate nicely on your screen, the tissue below that the narrowest part is hypodense as compared to the uterus. Okay, so that is cervical canal, that is the cervix. And that you can appreciate only when you are playing with IV contrast, and if you have an injector, play with arterial phase, venous phase and capillary phase, and you will find lot of anatomy which you can appreciate, which you never did when you do external beam planning. Okay, so then that helps you to understand where your upper contour should be. So for example, here I would go at this level, right, and I contour so I would contour something here. Can you see that here? But posteriorly I have overestimated, so I'm just going back. So as you come down, this entire cervix you can see here. In this region I am not going to contour parametrium because uterine artery is seen here, right? So as I go down, now it is very clear to me. This is cervix. That's the parametrial tissue. Maybe go more here. More here. If I want to measure, again I will go back and do the measurement. 24. Fits very well, right? So like that, if you are able to do it in your clinical practice with clinical drawing at diagnosis, clinical drawing at brachy, and then MR image if at diagnosis or CT image at diagnosis. So if this patient didn't have an MRI at diagnosis, what would I do? I would easily directly measure this length, that's 6.5, right? So I would divide it by 65%. So 6.5 would be roughly around 4.5 or 4.5. So what I would do is my contour of high risk CTV would be in this region. Upper end would be at this level. So I would contour entire volumes here up to this level. So in that region, I overestimate high risk CTV when there is no information of MRI diagnosis. Second most important point when you are planning is, even in MR image guided adaptive brachytherapy, we are not very conservative when it comes to tandem loading. We don't reduce the tandem loading too much. So we still continue with standard loading. So having said that, your isodoses will be always here, right? So it will never reduce your doses. So that is why it is okay if you make it lower 2/3. Is that clear? When you don't have MRI information.
Doctor, what if I don't have a simulation with an IV contrast? How would I identify?
Yeah, it's a bit difficult. We tried doing that without the IV contrast, but it's very difficult. Uterine artery is a very important landmark for me.
So there's not another landmark either down
Isthmus, you will have to just see the isthmus. And second important aspect of IV contrast is parametrial tissue also is lit up with contrast. So you can make out better. So that's why I always say that CT protocol should have IV contrast. There is no substitute. Okay. Only the cervix, yeah. Okay, so let's see what you have contoured. Is that okay? Is that okay? Okay. So all user structures, okay. Oh la la, how many of you have submitted? No, save and submit. I don't think you all have submitted. So go to this button, save structures, and then at the bottom there's another command, submit final. Please submit. So by the time you submit, I will show you some example which was done in a recent teaching course in Europe. You see, of course, we did MRI first, contouring, and then I gave them information about CT, and then they contoured. After giving the information, you see how nicely the contours are, at least in this region. The second mistake everybody does is including part of the applicator into the target volume is not recommended. You can include the tandem, because you see tandem is very, very small volume here, very, very small volume. But at the vaginal level, the volume becomes big. It almost becomes double. And the reason why we say that is, if you have included the ring or the ovoids and your volume is 60 cc, high risk CTV, and I have excluded for the same patient and my volume is 30 cc, and you report that patient outcome after 5 years, I report the same patient outcome after 5 years, you say, oh, large volume, I have controlled this disease. But in reality, it was only 30 cc. Right? So the comparison will not be similar. So to have a uniform concept, plus applicator will never have a CTV, clinical target volume. Right? So never include part of the applicator in your target volume. Okay? Yeah, I will. This one, no, this is BGICC. Yeah. Why they are not seen? This one? Export. This one?
Yes. Those structures. Loop. And then close this one. And then just use that one.
Ah, yep.
But use some to him. Yeah, you know you have your.
Yeah, that's it.
So this one. Yeah, this one.
So there are a couple of you who have included applicator at the bottom, you see, right?
You can tell them if you have the vaginal extension down there,
Okay.
how they are going to
Yeah,
control and how they are going to do your plan. Are they allowed to do loading below the ring?
Yeah. So do you agree that you should not include the applicator? Yes. So a couple of you have done. There is somebody who has tried to exclude it. Very good, very efficiently done. This is nice, provided this patient had some vaginal disease at brachytherapy. So the part of high risk CTV, if you are including vagina, this is how you do it. Okay. And then accordingly, whatever loading has to be done by physicists will do loading, and you evaluate this plan. So this is very efficient way of contouring the part of vaginal wall if it is part of your target volume, excluding the applicator. No. So if it is let's say 9 o'clock to 3 o'clock, then only anterior half should be included. Or if it is 3 o'clock to 9 o'clock, only posterior half. So that is why if you see my clinical drawing, there is a clock. So vaginal disease, clockwise and lengthwise. So both if you document, then you can contour them correctly. Okay. The other thing I can see here very well is in SAG here. So quite a few of you have gone up to the level what the blue is master contour, let's say. Okay. So only 1 or 2 people have reached that. If you are a beginner, you want to be more conservative in terms of you can be generous, because if you are very uncomfortable that oh my volumes are very small and you have a uneasy feeling that oh I might be missing something, go 1 or 2 slices above, you will never be wrong. Okay, go by anatomical landmark of uterine artery, which can be seen on coronal here. Okay, so scroll the images to find out where the uterine arteries are. Can you see here? Appreciate in this region. Can you see that? Yeah. So up to that level, you're fine. If you're there at that level, you're fine. Okay. Here, couple of you have gone down into the vagina. This patient didn't have vaginal disease at brachy, so no need of drawing it as a part of target volume. What is more dangerous is some of you have contoured only this level. You have not gone higher up. I can understand time constraint, but very important is spend more time in target volume, high risk CTV, a bit more time as compared to OARs and the other volumes, because it is high risk CTV where we define everything: planning, prescription, optimization, and then documentation, volume, dose volume parameters, and then outcome later on. So you have to spend a bit more time. There will always be inter-observer variation when you start new in the department. So it is good if 2 or 3 of you together question each other. First 10 cases, question each other. Okay, why have you taken this upper border here? Why not here? Why have you taken lateral border here? Why not here? My clinical examination was like this, your clinical examination. By doing that interactive sessions for contouring, the efficiency of contouring becomes even better. And second most important is everybody starts contouring in the same way. But on the contrary, if Dr. Niyamat, Professor Niyamat says, no, I contour the way I want, and next week, second fraction, I am contouring the way I want, it will be a disaster. Okay, so it is very important that you have collaborative effort within your department colleagues. When you're contouring, have a consensus for at least 10-15 patients. Then automatically everybody will be start contouring on the similar lines. Okay, so this is very important. Okay. Okay, last few questions. Anything?
Thank you very much.
So how many of you will start doing contouring on CT? All of you? Okay. Sure? Good. So next time when I come for the conference, I would see your contours, not mine now. Yeah? Okay. Okay, thank you very much.